Welcome to On Becoming a Healer. I'm Saul Weiner. This month, the Institute for Healthcare Improvement has added a course I developed called Contextualizing Care for the Clinician, and they've added it to their subscription series. It's designed to meet the new foundational competencies on integrating patient and caregiver context into patient care. For those of you who are not familiar with the Institute for Healthcare Improvement, or IHI as it is commonly called, they're a nonprofit provider of flexible, on-demand online courses designed to, quote, help students, clinicians, and organizations strengthen core skills in patient safety, quality, and quality improvement. Over 750 organizations around the globe subscribe to IHI, so there's a good chance your organization is doing so already. I first mentioned this course back in 2025, but at that time it wasn't part of the IHI subscription series, so it cost $10. Adding it to their subscription series makes it far more accessible, although you can still pay for it if your organization or you don't have a subscription. Now, in the interest of full transparency, I'm not paid anything whether you take this course or not. I was paid to help develop it. So for those of you who aren't clear about what contextualizing care is or what it means, I'm sharing now a few excerpts from prior podcasts where Stefan and I discussed it briefly. Usually comes up when Stefan asks me a question about contextualization of care that prompts some sort of discussion. So I'm now going to share with you parts of 6 brief conversations. And here in the first one, Stefan asks me how I got interested in contextualization of care. My interest in this started when I was a young attending, supervising residents. This was at a time when everybody was talking about evidence-based medicine, and physicians, particularly residents and medical students, were getting better and better at kind of knowing the latest research evidence and guidelines for everything and how to look it up. But I started noticing when they would come and present patients to me that while they were very into what randomized controlled trials showed and so forth, often when we go in to see the patient, something would come out while we were talking and the care plan would no longer make any sense. For instance, the patient just couldn't afford the treatment plan, or they didn't have the physical ability or cognitive ability to follow the treatment plan, any number of things like that. And so I started to realize that these were situations where if you were to audit the chart, it would look like the patient got really good care. It seemed like it was consistent with the latest guidelines. But if you'd actually been a fly on the wall and you knew what was really going on, you would say, this really doesn't make any sense. This care plan probably isn't going to work. And so that's where the term contextual error came from, the idea that the care plan was inconsistent with the patient's life situation or context.
I wonder if you could play out at least one example in a little more detail for us so we can really appreciate it.
Well, as you know, at this point, we have logged several thousand examples from the work we've done, but just to go back to that key part of my life, when I was first thinking about this, I remember a woman who I called Ms. Dawson. This example, which really got me thinking, started with a resident presenting to me a patient who was preoperative for having weight reduction surgery. And she met all of the criteria, the so-called evidence for benefiting from that procedure. She had complications of obesity, diabetes, hypertension, and so forth. She had not responded to other, more conservative approaches to weight loss. The only complicating factor was that she had had a prior surgery. She had her gallbladder taken out. So they were going to have to do this as an open procedure because she was at risk of having complications of a laparoscopic procedure for weight reduction. So the recovery period was going to be more like a month to 6 weeks. During the presentation, the resident mentioned that this woman was looking forward to losing weight. And that was because she thought she could take better care of her son. And when we were walking into the patient's room, I asked the resident, well, what's going on with her son? And the resident kind of looked at me like, well, why would we want to know that? I mean, the son's not our patient. So I was just struck by the fact that the woman had even mentioned that. It just was one of those things, if patients say stuff like that, you get curious. And so when I asked her, it turned out that this young man who was in his early 20s was actually dying of a serious condition. He actually had muscular dystrophy, and she was his sole caregiver. And so she was so focused on the idea that if she lost weight, she'd be able to take better care of her son, that she hadn't really thought about the fact that she wouldn't be able to lift him and bathe him, which is what she did for him for a month or two without risking wound dehiscence in her abdomen. That was kind of eye-opening. And when we talked to her about it and she understood the implications of having surgery, she canceled the procedure. So it occurred to me that if she'd had that procedure, it would have looked like the right thing to do, but it would have set her up for serious complications. And clearly it wasn't what she really wanted once she understood the whole story. So I think that's an example. That was a key example for me of how a simple comment like, I'm looking forward to taking better care of my son can often be a window, if you notice it and ask about it, into a whole story of what's going on behind the scenes that is critical to the care plan. And that missing that can land you a situation where that patient could have a very poor outcome, even though it looks like you're doing the right thing. And so that was my first revelation about contextual error.
So the context here is a responsibility that this woman had for her son.
Yeah, absolutely.
Does the context have to be a family matter, or could it be a different kind of thing entirely?
Over the years, we've identified 12 broad life domains where context can be a major factor. And the one I just gave you would fall under competing responsibilities, like in this case, a caregiver responsibility. And by the way, not all of these are bad things. For instance, getting a job and having to work the night shift can be a competing responsibility that gets in the way, for instance, taking your insulin at the time or eating what you need to. So others include a financial problem, for instance, not being able to pay for medication, a loss of social support if you depend on somebody, for instance, to give you your medication or help you to get to appointments and they're no longer available. It can also be something that drives your behavior, for instance, an emotional state. If a person becomes depressed, for instance, you might first notice that their hemoglobin A1C for their diabetes all of a sudden gets out of control. Their A1C goes up. Their diabetes is no longer well controlled because they've lost the focus and the motivation to take their medication as directed. So unless you recognize and address the depression, you're not going to be able to manage the diabetes. So these are all examples of changes in a person's circumstances or their behavior that are part of the context of a clinical presentation. And if you overlook them and you are sort of narrowly biomedically focused, you can end up with a care plan that looks good on paper, but is just not likely to be the right plan for that patient at that time. Okay, so now in this second excerpt, Stefan asks me to define patient context. That in turn led to my walking through the 4 basic steps to contextualizing care. What is patient context? Patient context is anything that pertains to an individual's circumstances or behaviors that's relevant to planning their care. So if you're trying to figure out how do I make sure that this patient is able to adhere to this treatment plan or understand why they're having such a hard time doing it, I need some context, right? I need to find out, are there particular barriers to why this person is not making it to appointments or that they seem to get very anxious and pull back when we talk about certain things. And so my job as a clinician is to pick up on those cues, to find out what's going on, to see what I can learn from that individual, either by observing them or by just things they tell me, and then to take that into account in the care plan. And that is what we mean by contextualizing care. And you'll see that I laid it out to you actually as 4 steps, right? So the first step was noticing those clues that a person is struggling with some life issue. It could be a patient saying, I'm sorry, I'm just not going to take that medication right now. It doesn't seem right to me. Anything that a patient says or that you observe could be a clue that there's something going on. And it could be in their head, like an anxiety, a lack of trust, or it could be something outside, a circumstance. And then your job is, and we call that the contextual red flag. Yeah,
That's the red flag. And I'm supposed to ask about it. If I'm a good doctor, I'm supposed to notice it and then inquire in some way?
Yeah, and we call that contextual probing. Hey, I noticed that you were supposed to go to cardiology and then also you're supposed to see the rheumatologist. I see you didn't make it to those appointments. Can you tell me about that? What's going on? Those would be contextual probes. And then the contextual factor would be what they tell you. And that's an iterative process. You may have to ask a few times. It could be any number of things, right? It could be, as I said, it could be a trust issue, an anxiety issue, an inability to afford something.
How about I can't afford the medicine?
Yeah, any of those things. We call that the contextual factor. And then the fourth thing is, what do you do with that? Let's suppose the patient tells you that as I said, their vision is poor and they can't read the bottle. And their caregiver has left town. It was their daughter who went off to college. Whatever it is, your job is to figure that out and to say, okay, let's work together to sort that out. And that's the process of contextualizing care. And as you know, we have audio recorded thousands of visits over the years, and we've measured each of these steps, whether they occur or not. And we found that physicians fall far short of doing this competently as a cohort. Some of them are better than others, but that's a competency, right? Because if you don't do that, you're going to end up with care plans that look good on paper. You prescribe the medicine that is recommended by guideline, but you're just ignoring the fact that there's so many indicators the patient is probably not going to be successful. So that's what we mean by contextualizing care. Okay, now in this third excerpt, I provide a brief description of the IHI course on contextualizing care. This is from a conversation we recorded last year when Stefan interviewed me just after we finished producing the course. I have been working over the last year with the Institute for Healthcare Improvement, or IHI, which is
Oh,
very
okay.
well known to medical schools. It's kind of one of the best known organizations that advocates for quality of care and that develops resources to improve quality of care. And they develop a lot of online curricula that medical schools use. And I've worked with them over the last year to develop approximately 3-hour module that can be broken in. It's 5 modules, but it's a 3-hour course that is entitled Contextualizing Care for the Clinician. And it walks the learner through, as I said, 5 modules. And at each point, there are exercises where you get to practice what you're being taught and see if you are effectively contextualizing care, and then it gives you feedback. And this course is based on the many studies that we've done on the key strategies to contextualizing care that are effective and that are most likely to drive better outcomes. Now, there have always been those who say that the medical school curriculum is so packed that there's not room to add anything. Somewhat rhetorically here, Stefan poses that question to me, which gives me an opportunity to vent a little bit. Have a listen.
Usually there's a fight at medical schools about how much time to give to things in the curriculum. Everybody's got their piece, and it's like, in the second year, we're going to give endocrine this many weeks, and we're going to give musculoskeletal that many weeks. Does this become a competing piece that somehow is going to now have to fight against neurology and endocrinology in order to get a piece of it? Or can it be, how's it going to fit?
To me, the idea that we would argue over whether to spend 3 hours of a 4-year curriculum on doing something that is foundational to being a physician and is essential to almost every medical encounter that we know affects patient healthcare outcomes and that doctors are currently not doing very well. To the idea that would have to argue over 3 hours for that is, to me, frankly bizarre. I do know people get into that, like, well, do we really have 3 hours of time? I'm like, I mean, give me a break. And again, we've had other episodes where we've talked about how much stuff is force fed to medical students from areas of basic science that none of us remember or ever use. So yeah, so I don't have a lot of sympathy for any medical school that would say, well, gosh, we're just too busy with biochemistry cycles that our students have to have down pat to spend any time talking about how you effectively take patient life circumstance and behavior into account when planning patient care. I think the other thing that's often assumed is that, oh, well, this is kind of common sense. You just have to be a caring person. And as long as they're professional and they care about their patient and they listen and they're, quote, patient centered, this will all happen. And that's just not what the
Yeah.
evidence shows. Over the years that we've had this podcast, I've periodically told stories about contextualizing care. Here's one of them. I'm just thinking, I was in clinic a couple days ago in urgent care, and the resident presented to me a patient who was concerned about a tender, painful lesion over their, I think it was their left eyebrow, and they said it swelled up in the morning. And they came in because of this concern. And the resident said to me, I couldn't see anything. It felt tender to the patient. The patient says it swells up in the morning. So I'm not really sure what to make of this. I'm thinking maybe we should refer them to dermatology. So I went in to see this patient. Again, I couldn't, their forehead looked completely normal to me. And when I pushed on it, they jumped back. They said it hurt. And so then I started pushing on both sides at the same time, and I got them distracted. And I realized that once I had them distracted, I could mash on it, and there was no response. They weren't feeling any pain. And so then I started asking, and by the way, this was a veteran because it was at a VA. And I started to wonder to myself, like, what's going on here? Why is this veteran come in actually it was a holiday and is so concerned about something that I can't see that looks completely normal and that doesn't really actually seem to hurt them when they're distracted? And so I started to think about, like, well, what could be going on here? And I asked the patient, like, what are you? And so the contextual red flag for me was this disconnect between the patient's anxiety and what I was finding on exam. And I said to the patient, have you taken any photos of this swelling up in the morning? And they're like, no, I haven't done that. And for me, physiologically, I just couldn't think of anything that would
Yeah.
make that happen. So I started to worry that there's something going on in this patient at the level of anxiety. And it turned out that the patient had a stroke some years ago, had lost some hearing in their left ear, And I asked them, what are you worried about? And they were worried that this could be some sort of, that maybe they had some blood clot. And they were very anxious. And they actually were kind of perseverating on that. And so I said to him, look, no, you're doing terrific. I see nothing for you to worry about. This definitely is not a clot. This is not at all related to a stroke. And they were so relieved. And I said, of
Wow.
course, you can take a photo. If there's any swelling, you can bring it back in and so forth. But that to me was a 4-step process of contextualizing care. And I think that was something that our resident didn't know how to do. They were like, I can't figure out what's going on. Let's refer this person to a specialist. Um,
Yeah.
right. But what they weren't picking up on was the contextual red flag. And that really is the process that's just one of a gazillion examples of the process I'm referring to that we hear physicians miss in so many different dimensions because they don't think of these things as contextual red flags.
Here, the red flag is that there's a discordance, a real serious discordance between the patient's apparent urgency about the problem and what you can observe. This usually results in just discrediting the patient or turfing the patient. Those are the two normal de facto responses. Pain out of proportion. I hate that phrase, completely hate that phrase. But what it is, oh, there's a discordance. That now is the thing I need to follow up on. And I now need to ask questions that would get any avenue possible into where this is at. And frankly, this resolved the problem. Like they could have made 3 more visits to different emergency rooms around town for this forehead issue, but for the fact that you kind of got them to lay out what they were really worried about. And then you could actually reassure on that front. And probably they went home thinking, yeah, my forehead doesn't feel right, but you know what? I'm all right with this now.
Yeah, and I will also say that afterwards, I had an opportunity when the resident wasn't busy to walk them through the 4-step process and show this as an example. And so it was an opportunity to teach it on the fly. And so I think it really is it's something that has to be taught explicitly, and not just in one example, but in many examples, so that physicians start to think about contextualizing care as part of what they need to do. And that's what I mean by physicians becoming aware of the structure of how this is done and then how to teach it. Okay, and finally, I'd like to share why contextualizing care has, at least for me, been the best antidote to burnout. Thank you all for listening, and I've provided a link to the IHI course in the show notes. Here's the final excerpt. At least for me, it's really something that brings joy to being a doctor. I think that the ability to see your patient as somebody who is facing a whole variety of life issues, circumstances, and behaviors, and to see your role as drawing that out and finding out how it relates to care is really such a deeply human thing. And I actually do think that some of the burnout in medicine comes from not doing that, from just sort of sitting at your computer and just being like, I don't know why this guy's fussing over that whatever on his forehead. It's not my problem. It looks fine to me. Well, maybe we'll have Derm look at it or whatever. I think that is what leads to burnout and a
Hmm.
sense of emptiness. But the ability to see that person as a human who may have anxieties, who may have concerns, who may be struggling with any number of things, to care about that, to draw that out, and to realize that that ultimately is going to determine whether your all the other work you've done is going to make any difference. Like if you're not finding out about that stuff, you're going to have this sort of sense that they're not going to take their medicines anyway. They're going to come back and see another doctor. That leads to burnout. I think capacity to value this critical subcompetency, to see it as something deeply human, something AI is not likely to take away from us if we can get good at it, and that allows us to see into our patients as fully human in the same way that we too have our neuroses and anxieties and financial problems or whatever they are. That's the joy of being a doctor. And so I think there's value for us as well as for our patients in taking this one seriously. We hope you've enjoyed this latest episode of On Becoming a Healer. If you have and you haven't already subscribed, please consider doing so now. Also, please rate us on the Apple Podcast app, as it will help others find us. And if you have a few moments, leave a review. In addition, if you'd like to make a comment about this episode, we'd love to hear from you. There are a couple ways to do that. If you're using the Apple Podcast app, then just open the episode website link and enter your comment there. Or you can directly go to the website contextualizingcare.org, select the podcast tab, and then scroll down and click on the episode. There you'll find the same comment box. Finally, you can always reach us at onbecomingahealer@gmail.com.